Good afternoon, everyone. Welcome to our weekly CEO Desktop Chat. Thank you for joining. A couple of preliminary instructions. We will be taking questions after the end of comments from Delvecchio and others this afternoon. There is a Q&A button at the bottom of the page. Please click on that, write your questions into the field, and we will try to get to as many questions as we can during the hour. My name is Terry Lightfoot, Director of Public Affairs and Community Engagement here for Alameda Health System. I'm glad to be with you. And if I can, I'd like to have other members of our panel introduce themselves, and then we'll have Delvecchio begin with his opening remarks. So let's start with Pallav, since she's the newest to our panel of Hollywood Squares.
Hi, everyone. My name is Pallav Babaria. I'm the Chief Administrative Officer for Ambulatory Services and also a primary care provider at the K6 Wellness Clinic. And thank you for letting me join this esteemed group of colleagues. No sarcasm intended.
I'm Janet McInnes. I'm the Chief Nurse Exec, Chief Administrative Officer.
And I'm Mark Amy. I'm the Chief Information Officer.
Tanvir Hussain, Chief Quality Officer. Terry, thanks for calling us the Hollywood Squares and not the Brady Bunch.
I have no reference to either of those because of my immigration status, and I'm Tony Redmond, the CHRO.
Love it. All righty. Okay, so apologies, we are just a few minutes late here, but probably like many of you, we've been on Zoom calls like all day, just about every day here. So yet another one, but really, as always, appreciate all of you signing on and being here, and most importantly, being here for our patients and our community and one another. But good afternoon and welcome to our weekly desktop chat. I want to start off with a couple of thank yous, or as I affectionately refer to them, my shout outs. Let's talk a little bit about community support, really continuous outpouring of support from our community, which we just so richly appreciate, and I just think is wonderful. Talk a little bit about our restoration efforts and where we are in the status of those activities. Talk a little bit about our supplies, testing, and I'm going to turn it over to Pallav and Mark to talk about ambulatory and telehealth and the great work that they've been able to do and are forging in that space. We'll talk a little bit about communications, as we always do, and then finally end with some points around self-care and wellness. So my shout outs and thank yous. So during the last couple of weeks, we've celebrated Nurses Week and Hospital Weeks with our teams, and now in honor of National Nursing Home Week, we'd like to recognize our post-acute staff who just rock, and they have continued to provide exceptional care to our residents in our skilled nursing facilities at Park Bridge, at South Shore, at Alameda Hospital, and at Fairmont. These exceptional care that they provide each and every day is phenomenal, and especially during this extraordinary circumstance. We've kept our residents safe, we've kept our staff safe, and we've made every effort to keep them connected with their loved ones. Your compassion, your dedication, and commitment to excellence is incredible, and I thank you for that. All right, turning on to community support. So I really hope you've been able to realize just how much your work is appreciated across the system. Last week, we had the National Guard honor you with amazing flyover. The prior week, we had first responders throughout the Bay Area salute us during a lunchtime caravan at Highland. We had other salutes at other locations, and those praises continue. We've had launch offers from various communities. We have another one coming up, I think, at San Leandro shortly that was just extended to us, and I'm sure others. Next Tuesday, the Sheriff's Office Color Guard is planning a show of appreciation at 1 p.m. in the passenger loading area in front of the main entrance of Highland Hospital. They'll be here playing the national anthem on bagpipes just in time for Memorial Day. And if you have the opportunity, please stop by, step outside, and enjoy the moment. And for those of you who are at other locations, please know that we will be streaming this live, on Facebook in case you can't be here. So thank you again. We really, really appreciate our fellow first responders and their support for our caregivers here. In terms of restoration, we are now in the second week of our restoration and recovery efforts, and many of our departments and their leaders have been working to develop plans to safely and to carefully restore key services. Key areas that we are focused on as a part of this effort is ensuring that we are defining screening requirements for vendors and healthcare staff, possible expansion of patient testing at additional facilities, assessment of adequate equipment and supplies, including personal protective equipment, hand sanitizers, and the like for our patients and our staff to ensure that we have sufficient quantity to resume hospital services and clinical services system-wide. Looking at our waiting areas and our public spaces to be sure that we have adequate signage and the capability of ensuring minimum of 6 feet of distance between patients. Finally, establishment of system-wide guidelines for telemedicine as we continue that effort, and also in-person visits when appropriate. As a part of these efforts, Alameda County has also eased some of their own shelter-in-place restrictions and now allow for curbside and storefront pickup from retail businesses and certain highly regulated vehicle-based gatherings. As we see the easing of the health orders, it's important that we continue to be vigilant, both within our system, but also in your personal walks. As you know, there's currently no vaccine for COVID-19 still, and we cannot let our guard down. Community spread of COVID-19 is still occurring, and it's important to continue to follow good hand hygiene practices, coughing etiquette, and personal distancing to avoid the increase in cases. Remember, we are not out of the woods yet. Turning over to supplies, as we begin to restore services, it's critical that departments are closely monitoring your PAR levels and following the processes in place to ensure that you're ordering supplies from materials management. We want to be sure that the appropriate PPE is used and we are not inadvertently utilizing supplies for higher levels of care. Please remember to monitor and plan your PPE orders with adequate time to ensure that we can get you what you need and what's appropriate for your areas, particularly for nights and weekends. Please also remember that as we begin to restore services and work towards a new normal, we are still in the middle of a pandemic. We will have to keep in mind, reminding ourselves that the guidelines that we put in place are still pertinent and still relevant to the work that we do, such as masking, personal distancing, screening. All those things have helped us to flatten the curve, and we will have to be as diligent moving forward as we have been thus far. Now turning to testing. Last week, we gave you a live feed from our brand new, right off the press opening site at San Leandro, and we were testing AHS symptomatic ambulatory patients at that particular location. This was, again, a very tremendous effort amongst many different disciplines across the system. Really proud to say the departments came together in a short period of time and successfully implemented an important service that will provide access for many of our patients. Not only are we reviewing the data from our own patients and our own experience here, we're looking at the wealth of information that Alameda County Public Health Department provides to show how COVID-19 has greatly impacted the health of the most vulnerable members of our community. The Healthcare for the Homeless program has been providing testing at the Operation Comfort site, and we are partnering with the county to find new ways and locations to support even more testing. As I mentioned earlier, the Restoration Oversight Committee is reviewing ways to increase our testing capacity, and Employee Health continues to coordinate testing for our employees. Now for ambulatory and telehealth. Often we focus on what's happening in our hospitals, and I want to take a few minutes to hear about COVID-19 impact in our ambulatory services, especially the implementation of telehealth. So I want to turn it over at this point to Pallav Babaria, our CAO for ambulatory, and Mark Amy, our CIO. Pallav and Mark.
You want me to start, Mark?
Absolutely, please follow.
So I think as many of you may already be aware, since the shelter in place went into effect on March 17th, ambulatory very rapidly pivoted to provide telehealth services. So prior to the shelter in place, we were not offering routine telephone or video visits in any of our clinics. We had a few small pockets where our pharmacists were doing telephone visits, but none of the providers. And then obviously with the shelter in place order, within 48 hours, we stood up an entire telehealth platform. So just huge kudos to all of the operational leaders, the call center, the referral unit, all of our schedulers, and especially the IT team who really helped us stand up an entire new visit type, figure out all of the Epic workflows. And, most institutions do this work over the course of months, if not years. So the fact that this happened within 48 hours without any major hiccups is nothing short of miraculous. And I think, just a huge testament to what we can all accomplish if there's a pandemic and a public health crisis and we all come together. So I think there's definitely some lessons learned from that experience for how we can carry this forward. What this means in practical terms for our patients is we now have an option for patients to get care that does not require them to come to our facility. And especially for our most vulnerable patients, those who are immunocompromised, who are elderly, have multiple chronic conditions, that option means that they can get care to maintain all of their current health and conditions and not risk their safety or their lives by having to come into the facility and expose themselves. Many of them take public transit. They don't have a way to get here without being out in public or on a public bus. So that has been great. And then more recently with ITU, we have a number of very successful video visit pilots going because we recognize that a telephone visit is not nearly as good as a Zoom call where you can see your patient, examine them, diagnose basic conditions just by looking at the patient. And so we're piloting those and, coming up with the sequencing plans that we can spread them to all of our clinics. So in current state, on average across our clinics, about 10 to 20% of our visits are in person. And those are for patients who really have urgent needs that just can't be met over the phone. If you break a leg, it's hard to treat that broken leg over a telephone visit. But the rest of our visits are being done remotely. And we've gotten just amazing patient responses. Our no-show rates have gone down, especially for our patients where even in the best of times, getting childcare, coming all the way to the clinics or the hospital was challenging. Our patients are loving the virtual visit option and it works much better for their lives.
Yeah, just to add to that, Paula, kudos to your team for the quick pivot. I've not seen anything like this. And I think for those of you that know me, I have a real passion for telehealth and what that gives to us. I think it's an equity item for us as an organization. But more than that, I'll share with everyone here. I'm also a patient of Highland Hospital. I get my treatment. So shout out to Dr. Nelson or any of his staff watching. They're awesome. But I had my first phone visit with them and it was great and it went great. And then all of my information showed up with the after visit summary in my chart, just the way it should happen for us. And it was so nice. I will say, Paula, I'm looking forward anxiously to my first Zoom visit with Dr. Nelson, but I don't have childcare issues and I don't have to take public transit. I'm very blessed on that, but it was still really nice to not have to go into the facility to potentially have exposure to COVID-19. Certainly appreciate all of our clinical staff, nurses rock in that do take care of our patients day in, day out in this way. But it's really been great with the pivot that we've been able to make there. A couple of other interesting things. One of them is our partnership with Epic. I've had a number of physicians and other clinicians mention to me they couldn't imagine going through the pandemic without Sapphire already in place. So very fortunate for us and great planning by our leadership to get this program implemented, and it's made it so much easier for us to prepare in that way. Epic themselves has seen an astronomical increase in the number of video visits that they're seeing across the country. So we're part of that wave, and I'm so excited. Like Paula mentioned, we've been able to do things in a matter of weeks and months that take other organizations years. And one of the core things that Paula and I are working on is making sure that this is sustainable as we go forward. So this means working with a number of our partners around how we change reimbursement models. It means making sure that we get the billing components in. It makes sure that this is a sustainable model for us from a security standpoint. With where we're going. It means partnering with Zoom, who many of you know. My daughter is on a Zoom class right now herself this morning, and she knows all about Zoom security, as many of us do. And in fact, she was educating me on some of that. It means changing really the way that we look at some of our work, how we're communicating right now as an organization, but certainly how we communicate with our patients. So I'm super excited about the technologies that we have coming together between Epic, the Zoom product, my chart, which is one of the things that's really near and dear to my heart, being able to carry my medical record around on my phone. And certainly as I look at how we're influencing all of our population, but certainly our most vulnerable population that does for the most part have access to cell phone and cell phone information, smartphones even, and being able to get them their medical record out in a way where they can reach out to us and connect with us in a meaningful manner.
And I just wanted to add one thing to, Mark's last comment, especially in that around equity, is I think we are realizing, and there is now a national dialogue that is starting about the digital divide that exists for the most vulnerable patients we have. So we know across the nation and even in the Bay Area that if you are lower income, your access to reliable broadband, your access to unlimited data plans where, one Zoom visit doesn't eat up your entire data for the month, your health literacy and your language, abilities, that if we have patient portals that are only available in English and Spanish, what does that mean for all of our patients who do not speak those languages? There was an interesting article that came out of San Francisco General where they were looking at, once they went to telehealth, what were the patient demographics who were accessing clinical care before and after the shift to telehealth. And there are clear patterns, for which patients feel more comfortable accessing technology and Zoom video visits and telephone visits, and which patients we need to maybe build infrastructure and to help navigate and train them to use those systems. So I think an interesting, a key need, and one that ambulatory really looks forward to partnering with both IT and our health equity committee is looking at, as we shift to telehealth, how do we not worsen healthcare disparities that already exist? What other modalities do we need to use to support our patients who may not be able to use the sort of set pathway because of some of those limitations?
Absolutely. All really pertinent points, and certainly things that we are acutely sensitive to and aware of. And I think it really have driven a lot of the successful efforts that you all have made, and that certainly keep us still aware of the work that we have yet to do. So thank you for that. Mark, thank you for both your professional and your personal perspective that you offer. So no HIPAA violation. He shared it himself. So it was great. And thank you for the succession planning work that you're doing with your daughter there for us too. So, when you're ready to retire, just tell her, we'll complete the interview process for her. So thank you. But really, thank you all. Really such important work for our patients, and to ensure that we can continue to serve them, and also not just make sure that we're focused on responding to the pandemic and those who are unfortunately and sadly befallen with COVID-19, but those who continue to have healthcare needs and outside of COVID-19 that we want to make sure are maintaining their healthiness and their health status, and that we're partnering with them to do that. So thank you so much. Just a couple of words on communication. I'm really proud of, similarly, internally, our ability to bridge the communication gap that this pandemic has brought on. The fact that we're not spending a lot of time in big conference rooms or meeting rooms together, but we are spending a lot of time online and face-to-face, and we've started to really truly optimize and leverage the connection that we can get from here. Recognize it's still virtual, but meaningful no less. And so the communication between our patients and their providers is important, and we're making sure that that's happening. We're making sure that communication with our patients and their loved ones, as they're having limitations on visitors and guests, is happening. And we're also making sure that the communication between us is staying robust. That open communication is so key as we move towards restoration as well. So please continue to read the memos that are disseminated. We're still continuing on Monday, Wednesday, Friday cadence from the organization, or from the system, I should say. Our coronavirus resource page is updated regularly and always accessible to you for any information that's there. And we encourage you to go there. These desktop chats will continue every Wednesday at noon. We'll continue with some feature presentations here and there. And as I mentioned before, gradually we'll introduce other sorts of topics as well, subject to interest and relevancy to what's going on in our area and within our organization. Finally, we will continue to keep you apprised at a system-wide level of what our supply dashboard looks like. We're doing that both within the organization, but also in the broader community. So it may look different in your unit, and so don't take that as the indication of what's available on your unit. We're encouraging you, as I said earlier, to make sure that leaders in your area know what PPE stock you need, whether it's masks or gowns or face shields or hand sanitizer, what have you. Let's ensure that we're ordering that and making providing it to our frontline workers and our frontline healthcare providers to make sure everyone has what they need, but we'll also be providing you with a great lens for what it looks like across the organization and how we are continuing to take efforts in our supply chain group, in our purchasing groups and others to best ensure we have what we need to safely provide care to our community. Finally, I want to end with some notes of self-care and wellness, as I always do. We're moving into Memorial Day weekend, and it's important that we take a moment of silence, as always, to reflect on the millions of lives lost across the world as a result of this pandemic. And with that, we haven't done this, and I hope you'll indulge me, but I'll take just a brief moment of silence to truly do that. So. Thank you. I really want to remind you all that every Wednesday we post a Wellness Wednesday message on our intranet. Today's message is the power of human connection. I'll read an excerpt for you. It's too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around. So let's make sure we don't underestimate the power of all of those small acts. Please take time to take care of yourselves and continue to take care of each other. Thank you so much. And with that, I'll turn it over to Terry so we can have our Q&A with the panel here.
Great. Thank you, everyone, for those initial comments, Delvecchio, Pallav, and Mark. Really appreciate them. To the audience, please make sure, if you weren't on with the initial instructions, there's a Q&A icon at the bottom of the screen. Click on that icon, write your questions into the field, and we will try to get to as many questions as we can during this particular chat. There's a couple of cleanup issues. So that there's been a lot of, you may have received a lot of invitations and cancellations regarding this meeting. Just want to clarify, I guess there's, and Mark can correct me if I'm wrong on this. I think what happens is when we set these up on a weekly basis and then cancel them all, there was mass cancellations and rescheduling going out to the entire staff. So some of you received many of those. Apologies on our part for the inconvenience with that. I know they were popping up on my screen, and so we have a new process we'll put in place to make sure that doesn't happen again, but we'll square that away. Pallav, I wanted to go back to you as we talk about telehealth and telemedicine. Can you share at all what have been some of the reactions from patients who have been taking advantage of telehealth?
Definitely. As I mentioned, I think almost universally our patients have loved the telehealth option. I do telehealth visits with my own primary care panel of patients, and I can tell you many of them thought we had closed, that we weren't providing services. So not only were they delighted that we are actually open and available to take care of their chronic needs, refill their medications, address any new issues that have come up, but they really appreciate the fact that they don't have to come in. And many of them, obviously feel safer staying at home and still being able to talk about concerns with their provider. I do think, there are certainly patients who need to be seen and that the services they need cannot be provided virtually. And one of the challenges that we are encountering is even for the patients who do need to be seen, many of them are scared to come in to our facilities. And I certainly spend a lot of time messaging to my patients that we are taking precautions. We're screening our employees, we're screening patients, we're using masks, we're socially distancing. So we had a case, just this week of a patient who clearly was having a heart attack and had to be talked into coming to the emergency room because he was so scared. And so I think just as we think about messaging and partnering with the community, how do we get the message out that people who need care should be coming in and seeking that care? And I think locally and nationally, we've seen an increase in non-COVID-19 related deaths from other conditions because people are scared to seek care.
Well, I'll add to that just a little bit. We are currently developing a communications plan to send that very message you just indicated about the availability of services, not delaying emergency care, that we will be distributing shortly, probably next week, to sort of reinforce that we are open for business and that emergencies don't take a break. And so we don't either. So there'll be a lot of information coming out about that, and we'll be working with you all and others to make sure those get to the right hands and to our patients in a timely and appropriate manner. So thank you for the reminder of that effort that we're undertaking right now. Okay. There is always a question about supplies, and maybe Janet, I'm going to hope you can handle this one, but I know there has been, I don't know, international intergalactic shortage of hand wipes and the like. So any update on where we are right now in terms of bringing in more wipes into the organization?
So good news, the Martians intergalactically just sent us a huge supply, so should put everybody's fears at rest. But no, it's a continued shortage, but it's something that our team is on, and they're sourcing as actively as they possibly can. And so, while we see a shortage, we are not at a critical state yet. The same thing with the hand sanitizer that fits in the little machines that hang on the wall. There's a definite shortage of that, but we found that we can use spray bottles and we can put desktop hand sanitizers around. And again, we're asking everyone to own this. If you don't see something and you don't see hand sanitizer, don't just walk away or not mention it and then bring it up 3 days later and say, I found 15 sanitizers that were empty. Please step up and find somebody to tell them, or call EVS. There's also a website that you can go to with them to request more. And so, again, we need to keep everybody safe, and I think it's everybody's job to take ownership of this. And so, again, the short answer is we are actively sourcing supplies as quickly as we possibly can. We may see things in a different form than we're used to, but we still have what's appropriate to keep everybody clean and safe and sanitized.
Great. Thank you. At last week's show, we missed one of our stalwart co-stars. Mr. Redmond was not available to us. So we did have a question for him this morning that we will point in his direction. Tony, there's a question about hazard pay and incentive for staff who are continuing to come to work every day to take care of our patients. This has been a question has been asked in a variety of different forms over several weeks. Can you comment on that at all for us?
Yeah, sure. Thanks, Terry. So I understand the question. I understand people's concern. I know that this has come up in the context of employees being out on FMLA or COVID leave. We're trying to balance what is a very difficult situation. And so we put the leave programs in place for those employees who were either asked to stay out because they were potentially infected with COVID and we were trying to protect them, their families, our patients, and other employees, or schools were closed when we had no other alternative. We are always, when we have benefits, trying to balance the cost of the benefit and the value to our employees because we have finite resources. We didn't receive extra funding for those. We're absorbing the cost of those leaves, and it is substantial. Our assumption is always that the employees take leave because they need it. I don't know if someone may or may not from time to time take a leave because it's available as opposed to a real need, but my assumption is the best, that our employees want to come to work, they choose to work in the safety net, they care about our patients and each other, and that's why that benefit exists. It's a safety net for our employees, the same as ESL, short and long-term disability, and I presume that our employees that need it are using it because they have to, not because they want time off from work. As it relates to hazard pay, we have finite resources. I would say at this moment in time, we have significant losses because of the reduction in volume and that our costs have not gone down. We cannot commit to making additional payments beyond those that we're already committed to at this moment in time. That doesn't mean we don't continue to look at our benefits. We don't continue to look at our situation on a daily, weekly, and monthly basis. But I couldn't, in good conscience suggest that we're in a position to make additional payments at the very moment when our resources are being stretched to the absolute maximum. We do know that the people that are coming in every day are being stretched. We do know that we're using temporary resources from outside. We did have to pay some premiums that were high when the market was high related to travelers, but those are being ramped down now, and we're working with our vendor Vizient to reduce the costs of those additional nurses in line with our ability to pay and what the market is now demanding. So we're constantly looking at these things. It isn't a matter of not wanting to reward our employees. It's not because we don't recognize the strain that is on them coming to work while people are on leave. But we have finite resources, and it's always a concern to us that we're trying to strike a balance. Sometimes we get it absolutely right. Sometimes we make mistakes, and we have to course correct. But we are focused on making sure our patients are safe and caring for our employees at the same time. And it's a delicate balance that we're trying to strike, but we will continue to try and do that. And we do take the feedback from employees seriously. It's not being ignored. We are concerned about it, and we do continue to look at it. But again, we're trying to strike that balance, and it's difficult.
Great. Thank you, Tony. Mark, this question, I'm going to point in your direction. Are there any plans to integrate data from any mobile health tracking apps or wearable health devices into the Epic platform?
I almost feel like that was a planted question out there, Terry, because anybody that knows me knows that that's actually part of the passion that I have, is extending our patient care to the home. Short answer is no, we don't have anything right now on that. We are still going through optimization of our implementation of Epic. We also have the big telehealth initiatives that we have going on in that. So that's the short answer. The longer answer is absolutely, we do want to do this. It's something we've been talking about on our roadmap, but it's not in the immediate future for us. But it is part of the emerging trend for healthcare and goes hand in hand, obviously, with telehealth. And I know Paula and her team would love to have that sort of information coming into the medical record on a regular basis. And so we want to be able to do that, but it'll be a future initiative for us.
Great. Thank you. There are ongoing questions about telecommuting, working remotely from home. Tony, can you give us some insight on what we're doing as an organization to assess the ability for us to look at that in the future?
Yeah, thanks, Terry. I think it's a great question from the employee, and it's a question we're assessing across the organization. I think much like telehealth, COVID has opened our eyes to what the possibilities may be. That doesn't mean that everyone that is working remotely will continue to do so, but it also doesn't mean that everyone will need necessarily to come back into the office 100% of the time. We moved very quickly to expand remote working. It may not have felt like that to the employees, but we did for an organization our size. And we waived a lot of conditions that typically would be in place. What we are doing now is assessing what work can reasonably be conducted from home or in a remote fashion, what the technological resources are that would be required for us to maintain that. Even though we are doing it now, it takes ongoing maintenance and costs to do that. What support structures need to be in place. Those are things such as, how does a manager manage a team remotely? You know, doing so for a couple of weeks or a month is very different than doing so on a constant basis. How do they assure productivity continues? How do they measure that in a fair way for the employee and for the organization? How do we deal with workers' compensation issue and things that seem very granular in nature but are important for us to assess? Ergonomic requirements for an employee who works from home all the time, HIPAA requirements when they may have other family members working from home. We're working through each role that is working remotely now, and some or many that are not, to make an assessment of what we can continue to do going forward and what other roles we may be able to add to that. So it's not going to be an immediate answer, but we're working through that with the business partners, our workers' comp provider, our ergonomic provider, our IT partners, and the organization at large, the operational leaders who are going to have to manage people in a different way than they have in the past. So we're making an assessment of all those roles. We will look to move forward with those that we can continue or could be moved out, and it may be in a hybrid model. But we are very much paying attention to this, and we are trying to work through this to get to a place that is a balance for the organization and to support our employees.
Great. Thank you, Tony. Tanvir and maybe Janet on this question around testing. We talked about opening of our San Leandro test site last week. There is still a question about staff being automatically tested and whether they are symptomatic or not. What's the rationale for that continued process right now? And do we see a potential change in that in the future?
You want me to take that or start, Tanvir? So I think that's a very good question, and a question that continues to come up. And so short answer is it continues to evolve. We are looking at adding to our testing sites. Initially, we stood this up, the drive-through at San Leandro, to accommodate symptomatic clinic patients so that we could get those patients through in a safe way, that we weren't bringing them into the ambulatory clinics and then having to expose people that way. So that was the initial stand-up. The second tier on that really is to look at pre-surgical patients and how do we give them access so that we can screen them and clear them so that they can, we can restore services for surgery. At the same time, we're currently looking at, do we have the ability to accommodate symptomatic and then asymptomatic staff, and then what are we capable of offering to the public as well? And so those are all under consideration at this time. I think we all hear about the curbside testing sites where people can just come at will and everybody gets served. We are not quite there yet, so we need to assess our priorities in this. We need to assess how many tests we have available. How does that filter back through a mechanism where the patient would find out if they were positive? If they were not affiliated with AHS, how does that work in terms of connecting with the physician? So we've got a few things to work out yet, but certainly that's been on everybody's mind and in everybody's conversation. So stand by for that. We may have an answer at next week's desktop chat, but it is something that we're working through for sure.
Great. Andrea, did you want to add to that at all?
No, I think Janet covered it very nicely. I just say a couple of other things is even as testing capacity increases around the nation, the county is also working on increasing its testing capacity. And Janet really nicely articulated some of the priority groups where they themselves are making sure testing is available. So just to give you a sense, as the shelter-in is slowly being relaxed, the county is trying to achieve about 3,100 tests a day to make sure there's adequate testing for those people at highest risk, the medically medically vulnerable, those who have been exposed, residents in congregate settings. So they themselves are trying to prioritize testing for those groups. The second thing to keep in mind is that even as testing capacity increases, which is important, please let's not become lax or feel too secure in terms of our infection control practices, which include masking, hand hygiene, social distancing, protection in terms of aerosolization, and that will be critical both in the hospital environment and as well as externally. I also just on that note would highlight that due to everyone's sort of vigilance around some of those basic human behaviors and disciplines, not only have we been able to keep our exposure or conversion rates low in terms of COVID, so too have you helped cause a decline in the CAUTI rates and the CLABSI rates and the C. diff rates. So I would just say from basic public health perspective, those infection control practices are going to be key because and the county too is working on trying to increase testing capacity to try to expand to other groups.
Great. Thank you both for those responses. Mark and Pallav, maybe you can share this question. Not sure who might best address it, but language barriers are difficult, even in an in-person setting. How are we addressing those via telehealth, telemedicine? What kind of mechanisms are we having? What are we doing to make sure that we don't have any gaps in care as a result of treating people through these new processes?
Paul, if I can take a stab at that from a technical, and then you might talk on the operational. So, Terry, great question. We are actually working with, so Dr. Cohen, our associate CMIO, and Megan, our PM on this, have been working a lot with how we integrate telehealth in using Zoom. We actually have a process right now. We're early in the pilot stage, but being able to introduce an interpreter into the Zoom conversation so that we would have both the patient and the provider and an interpreter all in on the same conversation together. And so that's a really important part of the work that we're doing around that. Obviously, it adds a little bit more complexity on the back end, but we're working through it. And certainly the providers, as they've been helping us pilot, have been helping us to make that process even simpler with what we're doing.
And I think, the phone visits are relatively straightforward. So all of us call interpreter services. So if a patient's primary language is not a language that the provider speaks, they will loop in interpreter services and then call the patient together. So there are no patients who do not have access to interpreter services via telehealth. And then, as Mark mentioned, we're trying to figure out, for the video visits, how we can incorporate video interpreters ideally, and piloting a number of different workflows. I do think that the big gap, which still remains to be seen, is for the non-verbal visits, really my chart. How do we engage patients who don't speak English and Spanish? And I would, I'm curious if Epic, as it starts to enter the safety net space more broadly nationwide, what they're thinking at that level in terms of language access.
Great, thank you. There was a question about what kind of testing are we doing? Are we doing antibody or antigen testing? Does anyone can let us know how that's taking place?
I can start with the...
And it's looking at you.
Oh, go ahead, Tanvir.
My response was going to be quite terse. The field of testing is constantly evolving, but at our organization, our primary methods are RT-PCR testing.
Yeah, and I think, I will editorialize a little bit, because I think the question specifically asked about antibody testing. And so there are certainly private labs and other entities that have popped up to offer antibody testing. But if you actually look at the nationwide guidance, both statements released by the CDC as well as the World Health Organization, scientifically, we have no idea what having antibodies really means and whether or not that actually protects you against reinfection, or if it does, to what degree. There are a number of research studies going on throughout the nation, and here in the Bay Area, Stanford has one. I think UCSF is launching one as well, to better understand how we use antibody tests. But I don't think any clinicians know what this test means or how to use it. And that is a big driver of why we have not pursued rolling it out at AHS, is that, if you're going to order a test, we should know what it means, and we should know how that changes your care of the patient. And we don't have those answers yet.
Great, thank you. Do we know, as we're looking at restoration of services, do we anticipate any particular changes in our visitation policy moving forward?
So again, this is one of those things that as we start to restore services, we certainly need to take a look at that. And, it's very uncomfortable for patients to have surgery, for example, and then be admitted to the hospital and not be able to have family members at the bedside to assist or support or comfort. And so, I also think we'll need to look at what the public health recommendations are, what the CDC recommends. How do we relax this and then, still at the same time continue to keep our staff, our other patients, and then the patient that certainly had surgery safe as well. So, and another thing that's evolving as we speak, but at this time, we have not made a decision to make any changes to our visitation policy. Anything to add, Tanvir, to that, or Paula?
No. Okay. Next question was, are we offering the drug remdesivir to our patients who are COVID-19 positive, and do we have a sense of how that's working?
The answer is yes, but I don't know.
Yeah, I was like, go ahead, Janet, or Tanvir, or Paula, go ahead.
To the physician, so can you speak to that?
I can. Dr. Baden is not on the call today, but in brief conversations that I've had with her, there is a limited amount of remdesivir that is coming in via the county and then being distributed to hospitals in the county. So I will leave it to other people exactly how many doses we are getting, but it is not an unlimited supply. And I believe the physician leadership of the acute side is pulling together a committee that is interdisciplinary, includes nursing, key stakeholders from various departments, and clinical experts to help develop guidelines on which patients should get that limited supply, because there certainly are not an endless number of doses to treat every single person in the hospital. So I know they're working on those guidelines.
Well, I think you covered most of it. That's great. Yeah, we did a lot of, I want to really give a shout out to Dr. Baden and the pharmacy and other leaders for actively working. our contacts and connections in the distributor community, as well as the advocacy community and others, to really underscore the need for us to have access to this drug for the patients in the community that we serve. And with a little snafu and a little bit of opaqueness at the beginning, we were able to get clarity around a process and understand how the drug would flow from the manufacturer. The federal government had basically commandeered it down to the state and down to the counties and ultimately to the hospital facilities. And through that work, we've been able to get a proportionately adequate supply or appropriate supply, I don't want to say adequate, based off of what was available and what we were experiencing within our 3 acute facilities. And so, as Dr. Barberia mentioned, there's more work to go to figure out how best to use that, because the indication we've gotten is that stock is pretty finite until maybe around August, when there could be additional batches available. So we're continuing to monitor that and be appropriately judicious and careful and thoughtful with how we use what we've gotten, and continue to seek and solicit more as it becomes available and is released.
Thank you so much. With the impacts of COVID-19 on the economy, also with impact of reduction in services that we've been providing, has had an impact on our budget. Delvecchio, can you say a few words about where we are in terms of looking at next year's budget, and any sense of how that might impact staffing or services you might provide at this point?
It's still a work in progress. We're in the phase of the budget process under normal circumstances where, and last year was a little bit of an outlier too, but usually around this time we'd be culminating like the second round of our budgeting review process, and probably about 80% done. Because of the pandemic and the response and some of the uncertainties that you articulated, Terry, we're not quite there. We're probably closer to about 50 or 60% in terms of our understanding of our own sort of forecasting of future needs, cost, revenue, reimbursement, and things that we'll see, and just the ongoing uncertainty around how long current shelter-in-place restrictions will be in place, our time for ramping services back up, whether we'll have a second wave in the fall, which is highly sort of anticipated in this circumstance, and what impact that would have on us going forward. So unfortunately, that creates a condition where what we've said to our board, and our board is concurring at this point, is we don't have enough confidence to be able to produce a budget, a full year's budget at this point. We'll probably be doing a sort of a short-term continuation of our existing budget, or maybe some slight modifications that address things that we were already intending to do, or imperatives that we already have that aren't necessarily impacted by or driven by the current pandemic. So right now we haven't gotten there. I'd be remiss if I didn't say, that things are tough for the rest of the world, and they're no different for us. And so we got the update from the governor last week. I think it was last week. They do the May revise of the proposal that they put out for the initial budget in January, and that demonstrated that the state is anticipating very, very significant shortfalls over the course of the year, to the tune of, I don't want to mess the number up, but I think it was somewhere on the order of like $56 billion or something like that. So obviously not insignificant at all. I think the rainy day fund was something like 16 billion. So far outstripping what the state has as far as resources. And as you know, a big portion of the funding for the population we care for comes from Medi-Cal. It comes from the state and the federal government. And so we're still trying to make heads or tails of what that impact will be on our revenue cycle going forward. Obviously the service needs and demands, we're having to calibrate under a new set of variables as well. The last thing I'll say in this respect, though, is while that becomes clear, please know that we continue to take every opportunity we can to advocate for relief. We really appreciated being able to get some of the dollars from the CARES Act early rounds of funding. We are optimistic. The House last week passed a $3 trillion HEROES Act. Some of that actually included, to the earlier question, potential benefits for hazard pay and things like that for our frontline caregivers. So we'll continue to monitor those things. We're advocating very proactively on the state and the federal level. We're working closely with our board and our county to underscore some of the needs that we had prior to this situation that are now permeating into and through this situation. And eventually through all of that, there's some things that have fortunately come to pass and have helped us out. There's some things that are still pending. So we'll see where we land, and we'll keep this group as well as the entirety of the organization apprised of when that becomes clearer for us. But right now, no plans have been finalized or concrete with respect to anything that portends dealing with the COVID-19 impact from a fiscal perspective.
Great, thank you.
Sure.
We have about 3 to 4 minutes remaining. I wanted to see, Davek, if you have any last words. Then we have a final question that we'll leave with, but anything you'd like to maybe share broadly with the group at this point before we sign off?
Not a lot. You guys, I always want to thank my fellow panelists here, my fellow Brady Bunchers. You guys are a wealth of wonderful resource. And I also want to thank everybody who signs on. Your time is invaluable. We appreciate it. You're asking wonderful questions, and in some cases we have good answers. Some cases maybe we fall short, but we're being honest on where we are. But we really want to keep the communication up, and this is helping us, and hopefully it's helping you. So thank you for the time. Thank you for the engagement. Thank you for continuing to be here or wherever you are, if you are remote working or otherwise, but continuing to support our community and our organization. So I'll turn it back over to you for wrap-up remarks, and we will look forward to talking next week with you all, if not sooner.
Janet, did you look like you had a comment?
Yeah, I just wanted to make a comment about something exciting that will start tomorrow. So we are starting a pilot to start reprocessing the N95 masks. And so there will be a pilot that will start on the SDU and ICU. More to come today. At the end of the day, we'll roll out some education and then start tomorrow night at 7 o'clock. ICU and SDU, you will see big plastic bins that will be distributed, probably 10 per unit. You will take off your N95 and put it in the bin. It will go to sterile processing. It will be processed through a hydrogen peroxide type of sterilization. And then we will put those into our stock for our reserve stock. Should we run short, we will have masks that have been processed. So this isn't something that Del Vecchio cooked up in his sleep overnight one night. This is a tried and true vetted process that has been used before. We followed very strict guidelines with that. We certainly wouldn't want to give somebody back a mask that was not processed. And so there's a lot that's gone into this. It's taken a few weeks to come to fruition, but that will be up and running. So if you work in the ICU or the SDU, you'll know what I'm talking about in another day. And then we will pilot that and then spread that through other organizations and other units as well. So I didn't want to miss that, so that people kind of knew what was coming down the pipe. So thank you.
Thank you, Janet. I totally forgot. I appreciate that. Hot off the press.
One last important question. Tanvir, looks like someone's noticed you've gotten a haircut. They want to know if there's a secret place you're going to get your high and tight done. Can you give any tips or directions on how to make that happen?
I was hoping the lighting wouldn't show it because it's basically the lawnmower that my partner used on my head. But don't tell him I blamed him for this. I'd be happy to share with you the product on Amazon. You might get a better result if you use someone else other than him.
Hopefully
I love him.
He's a better surgeon than barber, I hope.
Yeah, exactly.
We will we'll wrap up. Just remember that this chat will be posted online. I understand there may have been a problem with the link. We will look into that and make sure that's fixed. Thank you all for your questions and your time. Enjoy your upcoming weekend. And we'll look forward to seeing you all next week.